Hey, Ash here from All Things Dentistry. Thanks so much for joining me. I'm super grateful you're here. And, this is the place we love to share those unwritten hints and tips in dentistry. Well, those moments when you're doing a filling or a root canal or an extraction and the patient just kind of winces and like, I feel that. And you think, oh my gosh, I've given you, especially on a mandibular tooth, I've given you like 8 shots, 8 injections. Your lip is entirely numb. How can that tooth not be numb? Now, there's a whole bunch of articles, and I'm going to show you this article right here. This is a great article. It's in the description box below. Just sign up and you can download it, and it's got a great overview of some of the options to do for successful pulpal anesthesia for symptomatic irreversible pulpitis. Online, there's some key steps from this is from Spear, and also actually I'm going to have the link to this. Is a great video. I mean, it's got like 418,000 views, and this is the king, Dr. Stanley Melamed, talking about the inferior alveolar nerve block. And so it's a great review. But if any of this stuff doesn't work, one of the simplest things you can do is crack out the ligma jet. And I'll tell you, Dr. F taught me this about 7 years ago, and I've limited myself to endo and extractions. This thing I almost use probably 8 times a week. Super helpful. So what happens? Let me show you how it works. It's really a really simple little thing. You can use it with, so what happened here is this patient, we're going to extract this tooth number 4-6, and the reason why we're going to extract it, just before we get into this, is, let me show you the cone beam, is that this tooth, on the periapical, actually on the bite wing during an examination, just a routine annual examination, on tooth number 4-6, so here's tooth number 4-6, you're looking at the crown, and here is sort of the sagittal section. You see this large, dark radiolucency? Well, what that is one of our clinicians picked up, and it's an external cervical invasive resorptive lesion. So you can see in the axial slice here, this huge lesion here. And let's take a look at the coronal version. You can see that really significant lesion, and it's totally non-restorable. I've tried to restore something that's very similar to this, and it's not worth it. You end up taking it out anyway. So we elected for extraction. So one of the tests, what we'll do is we'll do the inferior alveolar nerve block. He has lip numbness, but I go to do the cold test on this tooth, and it's still positive. So before we anesthetize a patient, we check with cold to make sure it's vital or non-vital, and he responded to cold. So we redid the test, and actually the test in this case was actually the Explore into the lesion test, and he still felt it. So what we did, we're going to elect for, we're extracting this. I have a video on this in our memberships. If you join the All Things Dentistry team as a member, you'll be able to see the atraumatic extraction and actually the ridge preservation of this tooth. And so we're going to use the ligma jet. And what is on here, it's bent right now. It can be straight and bent, but this is an 8 millimeter, 30 gauge tip. And essentially all we're going to do is, let me turn the volume down, is we started off we're going to do in the mesial, and we're going to do one injection in the mesial. So I'm going to go nice and slow. Oh, let me just show you here actually. This is what happens. So when we're doing this procedure, it's super simple. You can do it with your regular injection, your regular syringe. I'm just using lidocaine 2% with 1 in 100,000 epi. But really the key is this short little needle. It's like I said, it's only 8 millimeters, and it's great because it doesn't bend that easily. And it's got to be 30 gauge. I've tried with the 27 short, and it just isn't big enough to get into that PDL space. And what we're trying to do is, this is classified as an intraosseous injection, but we're trying to get that into the PDL space. So I'm going to place that in, and all you need, I was taught doing 4 corners a long time ago, but honestly my experience now has been just in the mesial, a couple clicks of the ligma jet, in the distal, couple clicks, and then I'll retest for cold. One of the things you're going to watch, so this, if you haven't used the ligma jet, it's essentially what you see here, and it's just essentially, it's a gun. It's my PDL gun, that's what I love to call it. And I can place a lot of pressure, very slow, continuous force on this cartridge. But watch what's going to happen. If you go too fast, this will actually crack. Turn that down here. And you saw it crack right there. That's not a problem. On some of these, there's a plastic sleeve, and essentially the way that the carpule is designed is it doesn't break into a million pieces all over the place. It's self-contained, so don't give up on that technique. If that happens, reset and do it again. And what happened here is I was just going too fast, too much pressure with my large muscly arms. I'm just kidding. Going a little bit too fast for the anesthetic to get into the PDL space and the intraosseous tissue. So I'm going to reload. And Angela is my dental assistant. She's amazing. She's making sure, because what happens is if this flows out of the sulcus area, it is extremely bitter. Like we all know that this stuff tastes terrible. I often joke with my patients, if anything tasted good in dentistry, we'd have lineups out the door. But we don't. It was bad. It's always a bad joke. No one laughs at it. So let's reload. Okay, we're going to do it again. So we're going to go back in the same place. I'm going to go nice and slow. And as you sort of burrow a channel into the PDL space with more anesthesia, you can go a little bit quicker. So you can see I'm placing force. And you may ask, does that little tip break? I've been using this for 7 years. It hasn't broken, and I use it almost daily, this technique. And you can ask Angela. And what it does is it really speeds up anesthesia, because there's an algorithm in this document that talks about how, what are some of the choices, what can you do. And what I found is that sometimes it just takes longer for the patient to get numb. You may have even placed the anesthesia in the right place during your block, but they may take up to 30 minutes to get pulpal anesthesia. Sitting 30 minutes in a chair is a pretty long time to wait. This actually helps you speed up without having to go with a true intraosseous, an X-tip. And I have videos online about that, but if you feel a little bit hesitant to use that, this is a great alternative. Using this technique with the regular syringe is a little more complicated, because you got to place a lot of pressure. And the PDL gun, they're about a couple $100. They're not that expensive, and they will save you a lot of time and grief. And one of the biggest things I was trained to do was to do a cold test after you do your anesthesia before you do your treatment. Please, if there's anything you take away from this video, cold test before you before you anesthetize, cold test before you treat. It will make such a big difference in your confidence and your patient's confidence that, at 98% of the time, they're ready to go and they've got pulpal anesthesia. So as you can see, as we get more of a kind of a burrowing, if you may, into the PDL, I'm not sure if there's a better way to describe it. Now I can start to put a little more pressure, and it's going a little bit quicker. You have to be, so what we're looking for here, extra PDL space. We're looking for a little more of the blanching of the tissue just around the alveolar tissue. And then what we're going to do is Angela's going to give them a big rinse, or I'm going to give them a big rinse. You can see that tissue's blanched, so that gives me a good idea that, okay, we might be good. And obviously there's a lot of other injections you can do. You can do a lingual injection. You can do, in this case we did 3 inferior nerve blocks. I'll do a long buckle back here, and I'll also do, in this case, because we're doing extraction, I will also do an infiltration with articaine, 4%. So what we're going to do here is, because he has a direct channel, remember there's a direct channel into his pulp on the lingual, so if this is tube number 4-6, I literally going to take the Explorer and place it into that pulp. And if he doesn't feel anything, and he doesn't, let's see if I can ask him. Let's go back here. The poke in the pulp test. My humor is terrible. All right, here we go. Let's do it one more time. I just zapped him with it. All right, my friend, let's test this again. Pain there at all? Nothing? Mm-hmm. The poke in the pulp test. Oh yeah, so we're ready to rock. And honestly, that took total of probably 2 minutes, and it sped up our treatment. It decreased our treatment time. So if anything, take a look at the article, this article. Take a look at Dr. Melamed's great video online. And you know what? Give me a shout if you've tried it. Have you tried? My question to you is, have you tried the PDL gun, and does it work for you? So thanks so much for making it to this point. I really appreciate your time, and stay safe, and we'll talk to you soon. Cheers.